Gastric outlet obstruction is an gastrointestinal disease condition. Look at this picture shows that obstruction in pylorus. Look at this. Then abdominal X-ray, detailed stomach with air fluid levels. Look at these findings. Then barium meal study, detailed gastric emptying. Look at this finding. And CT scan, identify underlying mass, inflammation or malignancies. Look at this. Detail going on. Introduction. Gastric outlet obstruction is a medical condition that involves a blockage at the pyloric canal or the duodenum, which prevents normal gastric emptying. It is significant clinical problem that can result from benign or malignant causes. This condition requires timely diagnosis and management to avoid nutritional deficiency, metabolic disturbances, and overall decline in quality of life. Definition. Gastric outlet obstruction refers to any condition that mechanically impedes the emptying of gastric contents from the stomach into the duodenum due to obstruction at the distal stomach, pylorus or proximal duodenum. Etymology. The term gastric outlet obstruction is derived from Latin and Greek origins. Gastric from the Greek gaster meaning stomach, and obstruction from the Latin obstructor meaning to block or hinder. Together, the term refers to a blockage that prevents the normal passage of stomach contents into the small intestine. Epidemiology. Gastric outlet obstruction is relatively uncommon, accounting for about 1 to 2% of all hospital admission for upper gastrointestinal issues. In developed countries, malignancy is now the leading cause, whereas benign causes like peptic ulcer disease were more common historically. Types GOO can be classified into 1. Benign gastric outlet obstruction, peptic ulcer disease, inflammatory condition, example Crohn's disease, gastric polyps or Bezoar's. 2. Malignant gastric outlet obstruction, gastric cancer, pancreatic cancer, duodenal or periambulary carcinoma, metastatic disease. 3. Congenital gastric outlet obstruction, pyloric stenosis in infants. Causes: 1. Chronic peptic ulcer disease, scarring or inflammation. 2. Gastric polyps. 3. Crohn's disease. 4. Bezoar's, ingested indigestible material. 5. Post-surgical sutures. Malignant causes: 1. Gastric carcinoma. 2. Pancreatic adenocarcinoma. 3. Duodenal tumors. 4. Cholangiocarcinoma involving the duodenum. Congenital causes: hypertrophic pyloric stenosis in infants. Risk factors: 1. Chronic NSAID use causing peptic ulcers. 2. Helicobacter pylori infection. 3. Smoking. 4. Alcohol abuse. 5. Family history of gastrointestinal malignancy. 6. Previous gastric surgeries. 7. Dietary indiscretions. Complications: 1. Severe dehydration. 2. Electrolyte imbalances. 3. Metabolic alkalosis. 4. Malnutrition and weight loss. 5. Obstruction, pneumonia. 6. Delayed gastric emptying leading to gastric dilatation. 7. Gastric perforation is rare one. Pathophysiology. Pathophysiology of gastric outlet obstruction, GOO. Step by step process. 1. Initiating cause: benign or malignant. Chronic inflammation, example peptic ulcer. Or tumor growth, example gastric cancer, develops in the distal stomach, pylorus, or proximal duodenum. To tissue damage and structural changes. In beginning conditions, inflammation leads to edema, fibrosis or scarring of the pyloric region. In malignancy, tumor mass causes narrowing or complete blockage of the gastric outlet. 3. Mechanical obstruction of gastric emptying. The normal passage of food from the stomach into the duodenum is partially or completely blocked. For gastric retention and distension, food fluid and gastric secretions accumulate in the stomach, causing gastric distension and increased intragastric pressure. 5. Compensatory gastric motility. The stomach attempts to overcome the obstruction by increasing peristaltic contractions, which may become visible peristalsis. 6. Persistent vomiting. Due to inability to empty, the patient experiences nausea and vomiting of undigested food, often hours after eating. 7. Electrolyte and acid base imbalance. Vomiting results in loss of hydrochloric acid HCl, leading to hypocholemia, hypokalemia, and metabolic alkalosis. 8. Dehydration and nutritional deficiencies. Ongoing vomiting and reduced intake lead to dehydration, malnutrition, and weight loss. 9. Secondary complications, if untreated, may lead to aspiration, gastric perforation, or systemic effects of malignancy. This step-by-step process illustrates how GOO progresses from an initial local pathology to systemic complications. Signs and symptoms. A. Early symptoms. 1. Nausea and vomiting, often projectile and undiagnosed food. 2. Bloating, fullness after eating. 3. Early satiety. 4. Epigastric pain or discomfort. B. Later symptoms. 1. Weight loss. 2. Visible gastric peristalsis. 3. Dehydration. 4. Lethargy. 5. Electrolyte imbalance signs. Example, muscle cramps. Diagnosis. 1. Clinical evaluation, history and physical examination. Palpitation of an epigastric mass or visible peristalsis. 2. Laboratory test. CBC, electrolytes, liver function test, hypocholermic, hypokalemic, metabolic alkalosis. 3 imaging studies, A. Abdominal X-ray, detailed stomach with air fluid levels. B. Upper GI endoscopy to visualize and biopsy lessons. C. Barium meal study, detailed gastric emptying. D. CT scan, identify underlying mass, inflammation or malignancy. Nursing diagnosis. 1. Imbalanced nutrition less than body requirements. 2. Risk for electrolyte imbalance. 3. Acute pain related to gastric distension. 4. Risk for aspiration. 5. Anxiety related to illness and diagnostic procedures. Medical management. 1. Nasogastric decompression to relieve pressure and remove contents. 2. IV fluid and electrolyte replacement. 3. Proton pump inhibitors to reduce gastric acid. 4. Antiemetics to control nausea and vomiting. 5. Antibiotics if infection is suspected. 6. Nutritional support. Eternal, paternal nutrition if needed. 7. Treat underlying cause. Ulcer treatment. H. Pylori eradication. Tumor management. Chemo, radiotherapy. 8. Surgical interventional options. 9. Endoscopic balloon dilatation for benign strictures. 10. Pyloroplasty or gastrojejunotomy, surgical bypass. 11. Stenting, especially in malignant GOO. Nursing management. 1. Monitor vital signs and fluid status. 2. Measure and record nasogastric output. 3. Maintain electrolyte balance. 4. Administer medications as prescribed. 5. Monitor for signs of aspiration. 6. Provide psychological support and education. 7. Prepare the patient for surgical or endoscopic procedures. Treatment options. 1. Conservative management, NG tube, decompression, IV fluid, PPI nutrition. 2. Endoscopic management, balloon dilatation, placement of stents. 3. Surgical management, resection in case of malignancy, gastrojejunotomy, bypass procedure, pyloroplasty. Psychosocial medicine. 1. Emotional support and counseling, address anxiety and fear regarding procedures or malignancy, to patient education, explain the condition, treatment options and dietary adjustments. 3. Nutritional counseling, work with a dietitian to adjust food intake post treatment. 4. Family involvement, educate and involve family members in care and dietary needs. 5. Support groups, refer to cancer or chronic illness support groups if appropriate. Prevention: 1. Early treatment of peptic ulcer disease. 2. Avoid NSAIDs or use gastroprotective agents. 3. Eradicate H. pylori infection when present. 4. Regular screening for individuals with a family history of GI malignancies. 5. Avoid smoking and alcohol. 6. Timely evaluation of persistent GI symptoms. In conclusion, gastric outlet obstruction is a potentially serious condition that impaired gastric emptying due to various benign or malignant causes. Early recognition and appropriate intervention can prevent life-threatening complications. Multidisciplinary management involving medical, surgical, nursing, and psychosocial support is crucial for optimal recovery and quality of life. Thank you. Have a nice day.